with a short introduction about the issue and challenges associated with the hazardous drugs. And then we'll shift to discussion around our surveillance study, so that's our surfaces study, and talk about some of the results and learning from that work. And then we'll conclude with an introduction to new approaches and how we are thinking about applying those within our intervention study, which is called HazDEPP. So again, just as a brief introduction, when we talk about antineoplastic drugs, sometimes you'll also hear them referred to as chemotherapeutic drugs, sometimes cytostatic drugs, oncolytics. The terms are used pretty interchangeably, but they represent a large class of drugs that are mainly used in cancer chemotherapy. However, more recently, their use has been expanded to non-malignant disease treatments such as rheumatoid arthritis and multiple sclerosis. Chemotherapy drugs are compounds that are designed to prevent, inhibit, or stop the growth of tumor cells. So there are quite a large range of drugs that are in use with different modes of action, broad range of chemical properties, and a range of toxicities. So you can see under the NIOSH hazardous drug list, a list of different types of toxicities and target organs. And I should mention that the antineoplastic drugs are a subset of a larger category called hazardous drugs. So you may hear us sometimes refer to hazardous drugs. In this talk, if we say hazardous drugs, we're specifically referring to the antineoplastic drugs. Oops. All right, that works. All right, so in addition to the complex chemistries and toxicities, exposure characteristics with antineoplastic drugs is different than inhalation hazards in that these drugs are primarily, the primary route of exposure is dermal. And the dermal route of exposure is in many respects, more complex. Certainly from an exposure assessment and surveillance standpoint, it's more complex. We know from previous work, as well as studies that have been reported in the literature, that exposures to these drugs via these contaminated surfaces occurs widely through the clinics, and that the transmission occurs from surface to surface through cross-contamination. The drugs have poor warning properties. There are complex mixtures because the surface can and are often contaminated with multiple drugs, and that the exposures occur, while the surface levels may be lower than clinical levels, the exposures occur over a very long period of time, so chronically over that long period of time. And then there can also be exposures to these breakdown or reaction byproducts that occur because of incomplete decontamination and removal by the cleaning products, so that through that cleaning protocol.
Okay. So Susan and I are going to tag team this talk. So I'm going to take it from here and just talk a little bit about a study that I have presented before to this group. But there's some important evidence that came out of this study. Some of you have not seen it, which really sort of laid the groundwork for where we're headed. So in 2017, we undertook this study funded by the Alberta government called Surfaces, or Surveillance for Anti-Cancer Drugs. And the objective of that was twofold. The first was really to do a large exposure assessment on a scale that really hadn't been done before. So this is it looked at 2 different health authorities, Alberta and Minnesota. It looked at 9, well, I'm going to come to the details of it, a large number of hospitals over a lengthy period of time. We really kind of did as much sampling as we possibly could afford to do. And you'll see why some of the reasons why sort of been introduced by Susan, that this is a complex exposure, and you can't just take 3 or 4 measurements and really understand what's going on. But the second part was that we wanted to fill a gap around the strategies for both sampling and monitoring. And while we started to do that as part of surfaces, we really needed to take that one step further, and that's what the HazDEPP, the new study, is doing. So surfaces, yeah, it was very, very large. It was 9 cancer care centers, 3 in Alberta, 6 in Alberta, 3 in Minnesota. We looked at pharmacies and the daycare centers where drugs and antineoplastics are being administered to outpatients. We really sort of followed the drugs from cradle to grave, from the reception area right through to the recycling and what's the word I'm trying to look for? The final stages, the cleaning, the disposal. Thank you. That's the word I'm looking for. We were looking at 11 antineoplastic drugs over a 12-month period. We were sampling all these sites on pretty much a monthly basis for 20 different surfaces. So this was resulted in 22,000 measurements being made. So this is sort of a huge data set that we had to work with. The data results are summarized here. And so this starts to introduce or demonstrate some of the complexities that Susan was talking about. So what you can see, first of all, is that we were finding large variabilities by, in this case, region. You can see that Minnesota levels were higher. So the blue lines are the percent of samples that came back above the limit of detection. I'll talk about that in just a minute. And the red are the number of samples that reached a critical level we call a cleaning event criteria. And that was that when these occurred, the clinics were told that they had one of these events and that they should undertake a cleaning activity. So what you can see clearly here is there's a difference right away between the sites in Minnesota and Alberta, but also between the different sites within Alberta. There's a fair amount of variability from almost no cleaning events to several. So what underlies that, if you could see the data though, is from that previous graph, is that these drug contamination events are fairly rare, even at these very low levels. So they're occurring all the time, as you could see over 1 year. But in actual fact, when you look at the data closely, you find a lot of your results are below the limit of detection. So we call this data highly left skewed. And in fact, only 3 drugs gave us more than 10% of the data above the limit of detection. And they were gemcitabine, cyclophosphamide, and paclitaxel. So this means that this data is very challenging to work with statistically. And so again, having a few samples, you're going to really hit and miss with the kind of data you're going to get back. And even with 22,000 measurements, we ended up only being able to use a subset of that for the statistical analysis that we undertook. Now, this is my favorite slide of my entire career. So I always, whenever I get a chance, I always show this slide. This is an entire year's sampling from one hospital. And I just picked one for demo purposes. The y-axis is a log scale. So every bar on that is a 10-fold increase. Every single measurement from this hospital is shown here. If it's got a hollow center, it means it's below the limit of detection. If it's solid, it means it's above the limit of detection. And you're basically looking at these 20 sites from left to right. Is from the sort of entry point of the drug in the pharmacy, and there's the dotted line showing the difference between pharmacy and nursing. And then the far right-hand side is sort of almost towards the disposal end of things, heading out into the sort of patient area, washrooms, and so on. So what you can see, if you pick any one surface, like the BSC work surface, you can see that there's not as much variability, but there are a number of samples. The different colors are different drugs, gemcitabine, cyclophosphamide, and paclitaxel. You can see not too much variability, but most of them are above the limit of detection. You can go across just a few to the hazardous drug fridge handle. So these are all surface wipes from us. We did no air samples. And you can see that the range of variability increases by an order of magnitude. And if you go far to the right, you can see that something like the patient toilet door handle, and this is well-known information that we've been basically replicating, has sort of 3 or 4 orders of magnitude in variability, and the exposure levels can be very high. So again, this is what's showing you what's happening across a whole year. That variability at any one bar is variability across a year, and across the x-axis is variability between sites, and the different colors are between drugs. There's a lot of information packed in this slide, but it does show you the amount of variability that you have to contend with very small amounts of data above the limit of detection. So I'm going to hand it back to Susan. So the next step was, what do we do with this data in terms of developing a sampling strategy that we could recommend to businesses?
Thank you. And the byline of that is, how do we do this with such a complicated, messy situation? So I just want to spend a little bit of time talking about some of the challenges of conducting exposure assessment for antineoplastic drugs. So unlike inhalation exposures, yesterday when we were talking all about inhalation exposures, and there's a lot of guidance around conducting and designing sampling strategies and conducting sampling, and those strategies are very mature. We have validated methods, so the NIOSH Manual of Analytical Methods gives us a whole old school binder of methods that have been standardized and validated. However, with antineoplastic drugs, we're talking about surface exposures for which there is, broadly speaking, a lack of guidance. We have no standard validated sampling methods. We have no standard sampling strategy. So I've got a reference here to the no 5 Whys, which I'll get into more in a minute. Health-based surface OELs are not widely available. So again, with inhalation exposures, we have, not that we have an OEL for every compound, but we do have many OELs to refer to. Not true with antineoplastics. And because of that gap, I'll call that kind of a key operational gap, then there tends to be this reliance on this presence-absence test, meaning above or below the limit of detection. And just very briefly, there's a real, well, there are a number of limitations on that approach, because as I mentioned earlier, we don't have standardized methods. The analytical methods aren't standardized. So that means depending on where you are and what lab you use, the analytical method could vary and the limit of detection could vary. So whether or not you get a positive or negative result is dependent upon the method that's used and the sensitivity of that. So because that will vary, that introduces uncertainty and it makes interpreting the results more complicated. And Hugh just mentioned we have a heavily censored exposure data set. Most of the data are below the limit of detection. So that not only makes the analysis more complicated, it also adds complexity to interpreting and communicating the results. And then finally, chemical analysis costs are high. The instrumentation that's used to analyze the results and the labor involved is fairly significant, and so each sample costs a lot, and that puts tremendous cost pressure. Yesterday I talked about efficient and effective strategies and how important it is to get the most out of every sample, and that's certainly true here. So there's a clear need to develop strategies that are responsive to these guidelines that are coming out more or less with enforcement power, such as USP 800 and MACRA, and develop strategy guidance that addresses the operational gaps in these guidelines. So talked about the 5 W's. The why is there because we have guidelines that are saying you should be doing this, and because we know that these exposures are occurring, and we need to understand that quantitatively so that we can take action, get out in front of it. The what? Well, if I'm going to conduct sampling, yesterday we talked about chemical mixtures and what do you do when you have a chemical mixture? Well, In this case, there are many antineoplastic drugs that are used in a facility. Which ones do I sample for? So we wanted to provide some guidance around that and whether or not we should look at a single drug or perhaps multiple drugs, which we're calling a panel of drugs. Which surfaces should I wipe? We know from studies that have been conducted that the surface level contamination is highly variable. And so we really have to be thoughtful and strategic about selecting the surfaces. How frequently should we sample? Some guidelines offer guidance on frequency, but we really wanted to understand not only what is recommended for compliance reasons, but how do we make sure that we're being effective and efficient? And then how do we interpret these results for the reasons that I mentioned on the previous slide? It's complicated, and practitioners need to know what the results mean. So we conducted a modeling study to evaluate different kinds of strategies, and what we really wanted to do was to identify the most efficient and effective strategy. So where we're going to have the most power. By effective, I mean that we will have a high power to detect contamination where it truly exists. And then efficient, by efficient I mean being able to detect those true positives with the minimum number of samples. So we conducted a simulated wipe sampling based on our surfaces wipe data set, which you mentioned earlier, using 10,000 iterations and considering 3 antineoplastic drugs. So specifically, we included cyclophosphamide, gemcitabine, and paclitaxel. And we looked at whether we would detect each individual drug as well as any of the 3. So any of the 3 is how we defined our panel. And I just mentioned here, why did we use these 3 drugs? Well, because these were the 3 in our study, as Hugh just mentioned, that had a sufficient number of positives for us to work with in our modeling study. It's important to note that we were limited in our study to 3 drugs as a panel, but we really feel that that 3-drug panel should be a minimum. If you can include more drugs, then you gain power by doing that. We looked at different frequencies, so annually, semi-annually, quarterly, and monthly. And then we looked at collecting different numbers of samples. So what's the efficiency, what's the effectiveness when we collect 2 samples, 5 samples, 10 samples, or 20 samples. And then we took those parameters and we looked at 3 different strategies. Initially using a random surface selection strategy, so randomly selecting the surfaces that we were going to sample, and then using the limit of detection as our benchmark, so that absence presence. And then we looked at a sentinel surface selection. And by sentinel surface, I mean that we are purposefully selecting surfaces that based on the frequency of contamination. So again, going back to our surfaces study, we could look at that data and see which surfaces had the highest frequency of contamination above the limit of detection. So we were very purposeful. We wanted to weight the odds that if a surface was contaminated, we would find it. And then we used that sentinel surface selection plus a quantitative benchmark, which I'll talk more about a little bit later. So in place of that presence absence, we used a quantitative benchmark. Okay, so I mentioned that we selected, first strategy was to use random surface selection, and important to note here that we made sure to split as evenly as possible the surfaces that were sampled relatively equally between pharmacy and then the patient administration areas. Because again, we know from our studies as well as others that contamination pretty much is door to door in these facilities. So it doesn't stop at the pharmacy, so our sampling needs to also be conducted beyond the pharmacy. So we looked at, as I said, 20 surfaces, 10, 5, and 2. So with a random strategy, we just randomly selected from those 20 surfaces that we used in our study. We randomly selected those. In the sentinel surface strategy, we intentionally selected our surfaces, again, both in pharmacy and patient administration, but we selected the samples that had the highest frequency of contamination. Okay, these figures are a little bit complicated, so I'll just explain. On the y-axis, we have the probability of detecting contamination. And I'm using that term contamination to mean a level above the limit of detection. And on the x-axis, we have the number of surfaces sampled. So the structure is the same. So let's focus on the graph on the top left. We have, in that case, we look at a sampling frequency of annual sampling, so once a year. And then each of the, do I have my pointer? Yes. So with these lines, each of the three lines that are the lower three represents a different drug. So the one on the lowest one is paclitaxel, and then cyclophosphamide and gemcitabine. The red line represents that panel. So that is, if any one of those drugs was detected above the limit of detection, and we consider it a positive sample. So you can see that as we looked at an annual sampling frequency, semi-annual, annual and semi-annual sampling. And then we have both the random surface selection and the sentinel surface selection approach. And you can see in these figures, there's a very clear inflection point where we gain power up to a certain point, and then the power gained by collecting additional samples really levels off. So that really helps us to see where we get the greatest efficiency. And we can see with the red line that shows the highest probability of detecting an AD, that's where we get the greatest effectiveness. So looking at all of the strategies, looking at the two different strategies and the different sampling frequencies, we can see that the most efficient and most effective strategy comes from using the sentinel surface selection and sampling semi-annually using the drug panel. So from that learning, we developed some guidance for wave sampling. One of the first recommendations was create a site-specific guidebook. This is something we found immensely helpful in the surfaces study and other studies. Because we were going back to sample repeatedly, it was really important that we go back to the same place to sample. And with many, many moving parts and pieces in these studies, it's hard to remember where that was. So having that guidebook with the visuals is really helpful. We recommend using the sentinel surface strategy. As you can see, that gave us the greatest power when we collected 5 samples, and then supplement the semi-annual sampling. For example, if some kind of event occurs, like a spill, then you may want to supplement that semi-annual sampling. Use that panel approach where 3 or more drugs, and then preferentially using quantitative benchmarks, which we'll talk more about in just a little bit. Okay, so I'll hand it back off to you.
Great, thanks, Susan. Yeah, just a couple of thoughts that came to my mind when Susan was talking. So some of that may seem, well, very obvious, but the drug panel, for instance, a lot of people just still look for one drug, and CP is often the one they pick, cyclophosphamide, probably just because it's got a legacy of use. But you can see in our study, it wasn't the most frequent, the most prevalent contamination. And similarly for the surfaces that people sample, often they're guided to places like the biological safety cabinet where drugs are prepared, because that's a real hotspot. But you know you're going to find it there. It doesn't really tell you a lot about exposure to people outside the pharmacy area, for instance. And it's often one of the most cleaned parts because people know it's getting contaminated. So those are important points. I just want to very briefly go over this because we're over the time, but there are gaps in regulatory guidance for antineoplastic drugs. We've already mentioned NAPRA and USP, which give guidance specifically to pharmacies, and they do talk about measurement as part of the regulatory guidance. But NAPA refers to USP 800, and USP 800 just talks about there's 6 surfaces. They include in biological safety cabinets, some very, you don't think a lot of evidence has gone into the selection of sites that they've selected, and no other information about sampling strategy in terms of the number of samples to take and the drugs that should be selected and so on. Now, WorkSafe has got a new section of the OHS regulations, section 642, that just has been released in December 2023. And so that's interesting. There was a fair amount of input given by various stakeholder groups. We've talked about most of this. I'm going to go on to this slide. And some of the feedback that we gave and others agreed with is that we really wanted to see measurements, exposure measurement included in these new regulations, and they were not, as it turned out. But this is what we said, and this is, I think, general principles for a hygienist that people have much disagreement in a room like this. The quantitative exposure assessment is required to fully characterize exposure and risk. And unfortunately, and I refer you to Hans Kronhope's paper that he wrote in response to somebody a few years ago, and I think he really does talk about this very eloquently. But what we argued, as the situation gets more complicated, there is an increased requirement for measurement and understanding quantitatively what's going on, and not stepping back and saying, well, it's too complicated. We think we should probably go with a different approach. So we understand why this has happened. We've talked about the complexities of the exposure, the lack of OELs, for instance. So within the current framework of WorkSafe BC and other regulators, it's hard for them to come up and say, you must measure if you've got nothing to compare your measurements to, like an OEL. So that led us to many months of sort of discussions, and really thinking about, well, we're in this position, we've got these complex exposures, no OELs, we've got all these other problems with this particular hazard that we discussed earlier, and so it's no big surprise that over time we're not seeing really good advances in reducing the risk. So we get study after study of surface exposures coming out, we don't really see overall reductions in the risk. So what we were looking for was a way of implementing or evaluating these new strategies that our group had come up with, that Susan just talked about, a new sampling strategy, and really embedding it in a system that made use of this quantitative data that drew the most that we could possibly, the most value we could get out of quantitative data, that was effective and efficient, and we think we've really done a lot of work on that, but also that it integrated shared knowledge. So one of the things that wasn't on my bio is that I'm the director of the Canadian Workplace Exposure Database, and in circles of occupational exposure database people, we realized the value of shared data, of communicating results, and the value added by building or breaking down the silos that most exposure data ends up in. A few measurements here, a few measurements there. And again, we were talking yesterday with the students about sampling. We were saying the most common number of samples people take before they make a decision, a risk assessment, is none. And the next most common number of samples they take is 1. Well, if everyone's got 1 or 2 or 3 measurements, you can't get anywhere. But if you combine those, then you can start making more sense of the data. So we looked at 2 different approaches, and these are incorporated into the sort of DNA of this HazDEPP study that we're going to talk about in just a minute. So one is hygienic guidance values, and this is a way of being able to use and giving people a target or a comparator